And I'm going to be showing you some advanced airway techniques today. Okay, so now we're going to go through how to position a patient in the lateral position. We're positioning ourselves at the patient's hips and checking their pockets to make sure there's no sharp objects. The patient's far arm is outstretched and the closest arm goes across the chest. Okay, the closest leg to you is being flexed at the knee, and then with your hands on the shoulder and the hips we're rolling the patient away from us, making sure we're maintaining the patient's spine and watching their head. Okay. The bent knee, we're going to bend it at a 90-degree angle, and the straight arm we're flexing under the patient's head to maintain this position. A common error that occurs during the lateral position is not having adequate flexion at the knee, which could cause the patient to roll over flat onto their stomach and obstruct the airway. Or also not checking the pockets properly, causing a needle stick injury. Hi guys, now we're going to go through the triple airway manoeuvre. So we do the triple airway manoeuvre so the patient has a patent airway and it's easier to look at an airway inspection. So the triple airway manoeuvre comprises of 3 components: neck flexion, head extension and jaw thrust. The first one, neck flexion, we're putting our hand on either side of the patient's head and we're tilting the neck backwards towards us. Once we've got adequate neck flexion, then we're going to go into head extension. So one hand on the top of the patient's head with your thumb pointing down the nose and the other one on the jaw. Then we're lifting the patient's head up and we're getting a pillow or a towel or something to support and maintain that position. Okay. There we go. So once we've got neck flexion and head extension, we're going into the jaw thrust. So we're running our fingers along the angle of the jaw and thumbs on the cheekbone. Then we're pulling up towards the roof and pulling the jaw forward. Okay. So a common error in this triple airway manoeuvre is either too much neck flexion or too much head extension. Okay, this would result in a kink in the airway, and obviously the patient wouldn't have a patent airway. Okay guys, now we're going to go through how to insert an orophageal airway or an OP, so that's this thing here. Okay, so first thing we have to do is measure it to make sure it's the right size. So we measure it by lining it up with the angle of the jawline here and the corner of the mouth. Okay, so that's an adequate size to this guy here. If it was too big, then it could cause trauma to the back of the throat, and too small, it wouldn't do what it's meant to do, which is push the tongue forward. So once we've got the right size, we've got to lubricate it, so just some water-based lubricant or the patient's saliva just to allow for easier insertion. And we're placing it in upside down like this, and once we get a little bit of the way in, we start to do a 180-degree turn and push it in until it's resting against the patient's lips there. Okay, so next thing I'm going to show you is how to insert a nasopharyngeal airway or an MP, which is this here. So we use an MP if a patient has trismus, so their teeth are clenched together and we can't insert an OP. So first thing we have to do is measure it. So corner of the nose to the corner of the earlobe, okay, to make sure it's the right size so it won't be too long or too short. Then we have to lubricate it, so get some medical lubricant. Okay. And we just want to make sure the diameter is not any larger than the nostril. Okay, so we're putting it in and then we're pointing it downwards towards the floor, so a 90-degree angle to the face, and we just want to wriggle it around until it goes down and it's sitting at the edge of the nostril. Okay, so like that. Okay, so the NP allows for a patent airway, obviously when a person has trismus or anything like that where we can't have a patent airway through the mouth. A common error with the nasopharyngeal airway is choosing one that's too long, which would cause it to go down into the esophagus and possibly cause a gag reflex. Okay, so now we're going to go through how to use a laryngoscope. And we use a laryngoscope to inspect a patient's airway, and we can see all the way down to the vocal cords. So the first thing we have to do is we have to check that the laryngoscope, the light is tight, white and bright, so it can't fall out. We're using the laryngoscope in our left hand and supporting the head with our right. Okay, so gently putting it into the right side of the mouth and sweeping the tongue across to the left so we have a clear view. We're putting a forward pressure down the patient's body towards the toes, making sure that we have no flexion of the wrist. Then we can look down into the patient's airway, trying to get the tip of the laryngoscope into the valvular groove. Okay, so just a forwards pressure like that, and we can see down the airway. Okay, a common error with the laryngoscope is flexion at the wrist like this, which could obviously cause damage to the patient's teeth. Okay, so now we've inserted the OPA, we're going to show you assisted positive pressure ventilation using a bag valve mask and a rigid face mask. So first of all, we have to get an appropriate seal on the face mask. We're wrapping it over the patient's mouth and nose and wrapping our fingers around the jaw to get adequate jaw thrust. And we're ventilating at 12 to 16 ventilations a minute. So we've got to maintain the triple airway manoeuvre, and it's going to be roughly 1 every 5 seconds. So make sure we're looking for rise and fall of the chest. And in this, obviously, we can see the lungs moving. So a common error when using the assisted positive pressure ventilation is not an adequate seal on the mask. So when we're ventilating, the lungs aren't actually inflating.